So this is Dr. Linda G, who got her MD from the University of Texas in San Antonio, completed internal medicine residency training at Oregon Health Sciences University, and did her clinical and research fellowship for infectious diseases here at NIH, where we love and miss her. And now she is an assistant professor at Rutgers, and has done all of her research really in tuberculosis, and we are excited to have come and give us a talk about said topic today. Take it away, Linda.
Thanks, Elise. I'm so happy to be here today and to see familiar faces. So as Elise mentioned, I did my fellowship at NIH, and Elise and I were co-fellows. And I stayed on working in TB, doing with my debut in TB research, working with Cliff Berry and Susan Dorman. And then since then, I've been at Rutgers, New Jersey Medical School for the past year and a half, continuing with TB research. So it's really a very exciting time in the TB field right now, as pertaining to pathogenesis, diagnostics, and treatment. So I was asked today to speak about TB treatment with a focus on drug-resistant TB. And so I'm going to focus on how we're currently revamping the toolbox for treating TB. So before the development of effective chemotherapy, we know TB treatment was primarily palliative and sanatoriums. We did also note that a small proportion of patients with TB actually also cured without chemotherapy. The age of building our current TB chemotherapy as we know it took place between the 1940s and the 1980s in a series of clinical trials in Asia and Africa by the British Medical Research Council. And this began with streptomycin and PAS, and then isoniazid was added along the way, and ethambutol. And then rifampin and PZA were added, which had the effect of greatly shortening the TB treatment for drug-sensitive TB to 6 months. And since then, remarkably, now over almost 40 years, we are still using the same 6-month therapy to treat drug-sensitive TB. Treatment for drug-resistant TB, which is currently based on mostly observational studies, is still 20 to 24 months with a huge pill burden. So fortunately, we've now arrived at a very pivotal time where we're going to be seeing major changes in the coming years for treatment of both drug-sensitive and drug-resistant TB. So I wanted to start with a case, and this is a patient that I saw at NIH. And so I don't know if perhaps some of you may be familiar with this patient. So we saw a 37-year-old woman from China. She presented with 4 to 6 months of cough, which worsened after 3 months, and also developed the onset of fever, shortness of breath, and hemoptysis. She was diagnosed at an outside hospital with TB by sputum testing and imaging, with culture positive TB, and she was discharged on first-line therapy with rifampin, isoniazid, PZA, and ethambutol, but had minimal improvement. She noted that she had a prior history of pulmonary TB in China about 10 years ago, and reported that she was treated. She couldn't remember exactly what the regimen was, but that it was a 3-drug regimen that included rifampin, and was treated for about 10 months. Here we go. She was otherwise healthy, had no surgeries. She was born in Guangdong province in Southeast China, pictured down here in the map. And she had immigrated to the US 2 years ago with her husband and her 8-year-old boy who was healthy. And no alcohol, tobacco, and her family history was rather unremarkable, though she noted her mother was treated for TB as well as a child. And on exam, when she presented, she was non-toxic appearing, no acute distress. She was sitting well on room air, and she was noted just on her exam just to have decreased breath sounds in the left upper lobe, but otherwise the exam was unremarkable. Her labs were also, so she had an elevated white count, elevated ESR and CRP, a non-reactive HIV screen, and a relatively normal lymphocyte panel. Otherwise, her chemistries and other labs on admission were bland. Her imaging showed bilateral upper cavitary disease. She also had notable bronchiectasis with tree and bud nodularity, especially in the right upper and middle lobes. So her sputum was taken and processed for cultures, again at NIH, both a solid culture, which is LJ, and liquid culture called MIDGET, Mycobacterial Growth Indicator tube, is the assay that's used. And from both cultures, she grew Mycobacterium tuberculosis. The isolate was sent for whole genome sequencing to look for drug resistance mutations. And proceeded to perform what's called phenotypic DST from the midget. So basically, the isolate is inoculated with certain drug concentrations at breakpoints of first-line drugs and then second-line drugs to look at whether it grows in the presence of those concentrations of drugs. And this is what I'll continue to refer to as phenotypic DST. And it's also remarkable, it's worth noting that it takes several weeks not only to get a TB isolate, but then it takes several more weeks to get your first line phenotypic DST, and then several more weeks to get your second line DST. And so this is her drug susceptibility testing results. So we looked at both the phenotypic and the genotypic DST. And according to both DST methods, she was resistant to first-line drugs, as well as several of the injectables, including kanamycin. Interestingly, she had a canonical resistance mutation in JAR-A, resistance mutation that is associated with moderate to high levels of fluoroquinolone resistance. However, her phenotypic DST showed that she was susceptible to moxifloxacin at both the low and high breakpoints. And this was later further confirmed by doing minimum inhibitory concentrations. So this is really quite interesting. And this is also not the only example where we can see phenotypic and genotypic discordancies when we do both forms of DST. So first, let's start with asking, how did our patient acquire such drug-resistant TB? And we know she had TB in the past, but it didn't sound like she had any prior exposure as far as we know to second-line drugs. So these are, here are two examples of studies that genotyped many drug-resistant strains and uncovered their epidemiologic links. And they estimated, one was done in South Africa and another in China, in Shanghai. And they estimated a range of between 60 to 80% of drug-resistant TB was actually due to direct transmission rather than acquired over time of treatment acquired over previous treatment courses. So while having a prior history of drug-resistant TB is certainly a risk factor, many patients with drug-resistant TB actually acquire it from direct transmission. And phenotypic DST, as we just discussed, is considered the gold standard DST. But as we also know, it takes weeks to months to get a result, and it's not practical for most settings, which don't even have lab capacity to perform cultures for initial TB diagnosis. So we're really counting on being able to shift to molecular DST to increase the accessibility and speed of drug susceptibility testing to guide appropriate therapy early on. And like other fields in ID, phenotypic DST is based more on epidemiologic cutoffs than clinical outcomes. In fact, we recently learned that its dichotomous breakpoints of resistance versus susceptible just capture the tip of the iceberg for drug resistance, especially for rifampin. So this was a study done in the Elan laboratory here at Rutgers, where they evaluated isoniazid and rifampin minimum inhibitory concentrations among TB patients who were treated with standard 4-drug regimen. The green line is the likelihood ratio for relapse for each MIC value. What's really notable here is that all of these MIC values are below the breakpoint for resistance. So all of these MIC values are considered susceptible and are what we call what has been coined sub-breakpoint MICs. And we can see that especially for rifampin, that for incremental increases in the sub-breakpoint MIC, there's a remarkable increase in the odds of having relapse versus cure. And so this is, of course, a limitation to having dichotomous breakpoints. Of course, in many settings, it's also not practical to set up MICs. Meanwhile, we've also caught glimpses of potentially added clinical value of molecular DST, where we can know the specific resistance mutation. So for example, specific RPOB mutations, RPOB is the gene associated with rifampin resistance, that have been implicated in cases with poorer treatment outcomes despite being still phenotypically susceptible to rifampin. And on the same token, specific GYR-A mutations have been associated with, that are associated with fluoroquinolone resistance, have associations with treatment outcomes independent of their MIC, as some of them can lead to a range of phenotypic resistance from low to high level resistance. So this provides potentially even more impetus to hopefully one day move towards molecular DST. But there's still a lot of work to be done before we can do this to capture molecular mechanisms that lead to phenotypic resistance. And only recently, we've been able to achieve over 90% sensitivity and specificity using mutations, using molecular DST to predict phenotypic resistance in our 40-year-old first-line drugs. But there's still a long ways to go with second-line drugs, especially injectables, which have also been around for decades, and second-line oral drugs, which are now being moved up on the treatment guidelines, and we'll be seeing them used more and more for drug-resistant TB. We have a growing number of molecular DSTs that have been recently rolled out and are currently currently in the pipeline. And these molecular DST platforms have increased the accessibility to drug resistance testing from 7%, from less than 10% in 2012 to 50% in 2017 to now 60% in 2019. The molecular DSTs range from low complexity probe-based tests like Cepheid cartridge-based tests. So this includes also Expert XDR, which we anticipate will be released soon. We evaluated Expert XDR in China and South Korea, and basically found that the XDR had comparable sensitivity and specificity in detecting resistance mutations to isoniazid fluoroquinolones and second-line injectables as line probe assays, although they were reported separately. So the line probe assays are what is used most broadly for molecular DST of second-line drugs. The line probe assays are essentially hybridization assays, but they still require a bit of hands-on time and processing. And so end up, rather than taking 2 hours or less, like gene experts, end up taking 1 to 2 days to perform. And in addition, there's also sequencing platforms which increase the adaptability to incorporate new genetic mechanisms of resistance as they're discovered. And whole genome sequencing will be the ultimate molecular DST, but only when feasibly performed directly on clinical samples. So until then, targeted amplicon deep sequencing has been more of a rapid guide. So let's go back to our patient. How will we approach treating our patient who essentially has pre-XDR TB by phenotypic DST and XDR TB by genotypic DST? It's important to review the objectives of treating active TB. So active TB being having microbiologic evidence of TB and clinical signs and symptoms. So the objectives are to reduce the bacterial burden in order to decrease transmission and individual morbidity and mortality, to eradicate recalcitrant TB populations to be able to achieve durable relapse-free cure, and to prevent the acquisition of drug resistance. It turns out that this is no small feat because TB has enormous heterogeneity. We can see incredible diversity microbiologically across with different TB subpopulations, as well as diverse histopathology and diverse lesion anatomy, even within a single TB patient at one point in time. So our approach is to rely on combinations of drugs with diverse complementary mechanisms that work against different TB subpopulations. Beyond having different direct action upon different TB subpopulation, each drug also penetrates differently into different types of TB lesion compartments. For example, rifampin and PZA do well getting into more poorly vascularized necrotic caseum, which is the hallmark pus of TB, whereas isoniazid and moxifloxacin prefer cellular vascularized compartments. So the combination of drugs is important to be able to cover all types of TB lesions that harbor different bacterial subpopulations. But how do we decide which combinations of drugs will be effective outside of conducting long clinical trials with many arms for trial and error? Even after 40 years, we still have actually a limited understanding of the role of each drug in our first-line regimen. So to address a way to design combinations, we took a current drug evaluation platform for TB that's supported by the FDA and Global TB Alliance. And this is called early bactericidal activity, which looks at the effects of drugs on, of the candidate drug on reducing bacterial counts over 14 days. And it does include use of the drug by itself and as monotherapy, but in over 40 published studies, resistance has not occurred except in one case of therapeutic doses of isoniazid for 14 days. So this method is safe. So we added a 2-week PET CT scan to EBA to evaluate early treatment responses in South African TB patients on various regimens of first-line drugs and moxifloxacin over 14 days. This was a pretty complex study. The 2 years of Manually segmenting each TB lesion from the PET-CT scan made us cry, but we saw that the very interesting findings. So the activity of each drug on reducing lesion volume and inflammation on PET-CT align more closely with the original phase 3 studies, including from the VMRC clinical trials, and our long clinical experience than did traditional EBA measuring bacterial counts in sputum. You'll also notice here that PZA led to an increase in the lesion volume over 14 days. And so one of the questions that came up is, why do we use PZA? We know from the original BMRC studies that PZA contributes to the ability to shorten treatment to the current 6-month regimen, and that we don't really see a benefit after its use after the initial 2 months of therapy. It turns out that we found, yes, PZA doesn't do much for many lesions, such as in this patient who was treated with PZA monotherapy for the first 14 days. These posterior lesions from baseline to day 14 actually got worse. However, we found that PZA can be incredibly effective against dense inflammatory lesions, such as pictured here in this left upper lobe. So one speculation for why this might be is maybe the neutrophil myeloperoxidase that's more enriched in these inflammatory regions allow for the more acidic pH of PZA. But the underlying mechanism is still to be determined. But this is a very compelling explanation of maybe why PZA's contribution is important, but limited to the initial 2 months of therapy when it's putting out large fires, these dense inflammatory lesions that are high burden early in the course of treatment. And we also additionally see that PZA makes an important contribution to the activity of isoniazid, where their activity together in reducing lesion volume is greater than their sum. We also see that moxifloxacin is also highly effective, as well as the regimen, the 4-drug regimen, the 4-drug HRZE or RIPE and MRZE are pretty comparable. Rifampin here, again, is a star, but we can't use it as monotherapy. Otherwise, we face the risk of acquired resistance. And if we lose the ability to use rifampin in a regimen, it's like losing the strongest workhorse that's pulling a wagon up a mountain. So you require more smaller horses, that is more drugs for a longer duration when we lose rifampin. So we're now going to go through a tour of new TB treatment approaches, which have been introduced within the last 2 to 3 years. And judging by the number of trials, will likely continue to emerge over these coming 5 to 10 years. So first, I want to start with drug-susceptible TB. The TB-TC Study 31 is going to change the way we treat drug-susceptible TB. The results are not yet published, but were presented at the Union World Conference on Lung Health back in October. The study found that among 2,500 HIV positive and negative adolescents and adults with drug-susceptible TB, a 4-month regimen of isoniazid and rifapentine, can't find my mouse. Oh, there it is. Isoniazid and high-dose rifapentine with the addition of PZA and moxifloxacin for the first 2 months was non-inferior to our standard 6-month regimen. And this was not inferior in all patient subgroups and with sensitivity analyses. So the study team is currently working with the WHO and CDC in the development of new guidelines for TB treatment. And this will have downstream implications for drug susceptibility testing, including now for moxifloxacin. So moving on to drug-resistant TB. So the WHO estimates that there were approximately 1 million isoniazid monoresistant TB cases, but more importantly, about 500,000 rifampin-resistant TB cases, at least rifampin-resistant or more TB cases in 2019. And thanks largely to the global rollout of Gene Expert, the testing rates for rifampin resistance have increased greatly, as I mentioned, from less than 50% to now 60% in 2019. But still, only about half of patients with rifampin or MDR TB, which is rifampin plus isoniazid resistance, actually complete therapy. So just to quickly start first with isoniazid resistant TB. So this is isoniazid monoresistance. So maintaining susceptibility to rifampin and fluoroquinolones. A meta-analysis of mainly observational cohort study looking at individual patient data found that there were higher success rates and also lower mortality rates when adding a fluoroquinolone for 6 months to the treatment course for isoniazid monoresistant TB. And so the current guidelines recommend the use of levofloxacin for 6 months in the regimen for isoniazid monoresistant TB. But the meat of drug resistance is rifampin resistance, when we have rifampin resistance or multi-drug resistant TB. So this is where we lose our most effective drug, rifampin. And our current approaches to treat rifampin and MDR TB range, is generally at least 4 to 5 drugs for around 20 to 24 months. And of course, this is associated with tremendous multi-fold increase in the price tag, the burden, and the toxicity of treatment for rifampin and MDR TB, rifampin resistant and MDR TB. So in 2019, a new set of treatment guidelines for drug-resistant TB came out. And this set of guidelines really prioritize oral and shorter regimens. So starting with uncomplicated, quote unquote, MDR TB, where there's resistance to rifampin and isoniazid, but nothing beyond that, no resistance to second line drugs. There's currently a shorter regimen that's proposed. So in this shorter regimen originated in 2010, when there was an observational cohort study published by Van Don and colleagues, where they examined treatment outcomes of patients with lab-confirmed MDR TB in Bangladesh over a period of 10 years. And they found that the most effective regimen appeared to be a 9 to 11-month regimen, which cured 88% of patients. And this they referred to as a Bangladesh regimen. This Bangladesh regimen was then taken into a randomized clinical trial done in 4 Asian and African countries with inclusion of more HIV patients. And this was called the STREAM trial. This trial found that the shorter 9 to 11-month Bangladesh regimen, which consisted of moxifloxacin, so that was the only change they made. They replaced gadifloxacin in the original Bangladesh regimen with moxifloxacin. In addition to clofazimine, pyrazinamide, ethambutol, supplemented by kanamycin and prothionamide in the first 4 to 6 months, was non-inferior to the locally used WHO-approved MDR TB regimens, which averaged a duration of about 20 months. There's a phase 2 to this STREAM trial, which is looking at a 6-month regimen that essentially swaps out prothionamide and ethambutol for bedaquiline. And so it'll be interesting to see what their findings are in the next year or two. But now when we think about how to treat uncomplicated rifampin resistant or MDR TB, in general, the WHO advises first considering if they're eligible for the shorter regimen based on whether they have complicated infections like CNS TB or known or suspected resistance to second-line drugs in the regimen. And if none of these apply, then the recommendation is to use the shorter 9 to 11-month regimen. But our local US and European guidelines weren't, the guideline committees weren't as enthusiastic about this shorter regimen. And in fact, did not make a recommendation for or against its use. The major reason was that the shorter regimen didn't seem to pose any advantage with toxicities when we look back at the stream trial. And this was especially with regard to QT prolongation. There was also an 8.5 versus 6.4 rate of death among the shorter regimen compared to the standard longer regimen. And although very small rates, very small numbers, there were more TB related death. So which guideline should we go with? So at this point, for individuals with the uncomplicated MDR TB, the decision is really on a case-by-case basis, whether they're at high risk for QT prolongation, and of course, a decision made with the patient if treatment beyond 11 months is feasible. So what about the many MDR TB patients who don't do well on the shorter regimen or have complicated infections? So they have possible second-line drug resistance or forms of extrapulmonary TB. This is where we start looking back at constructing individual regimens for pre-XDR and XDR patients. But there are now a few key differences. So when we selected the regimen for our patient who fell in this category of pre-XDR versus XDR TB, we did this under the old 2014 guidelines, where second-line injectables and fluoroquinolones were the backbone of second-line drugs. And then this was followed by old bacteriostatic drugs, and lastly by group 5 drugs for which there was not much experience at the time. So we basically chose a regimen through a process of elimination, going with cycloserine, and later ended up adding moxifloxacin in the setting of phenotypic susceptibility. Understanding was with a grain of salt, bedaquiline, linezolid, clofazimine, and then meropenem paired with amoxicillin clavulate. Sounds like a menu. Since that time, oops, didn't advance. Our preferred regimen since that time has shifted to a strong preference for oral drugs. And based on a meta-analysis finding that oral drugs, particularly regimens that contain linezolid, bedaquiline, or fluoroquinolone, led to the most favorable odds of successful treatment outcomes, followed by clofazimine and cycloserine. Oops. And so this has led to the current guidelines in how we select the individualized regimens for pre-XDR and XDR TB or complicated MDR TB. So currently we are still using at least 5 drugs in the intensive phase, and according to our local guidelines, the intensive phase should last for 5 to 7 months after culture conversion, and to 4 drugs in the continuation phase to complete a total of 15 to 21 months of therapy after culture conversion. But then how we select these drugs, of course, has changed to a preference for levofloxacin, bedaquiline, or linezolid. And then if any of these cannot be used, clofazimine, cycloserine. And then the group C drugs, if group A and B drugs cannot, any of those drugs cannot be used, is ordered also in the order of preference. I do want to say a word about mixed TB, which is a trial looking at a 6-month regimen for XDR and complicated MDR TB. Remarkably, this 6-month regimen only contains 3 drugs, bedaquiline, protominid, which is a nitroimidazole that inhibits mycolic acid biosynthesis like the laminid, as well as linezolid. So at 6 months after completing the 3 drugs, they found in XDR TB patients and MDR TB patients, 89 to 92% favorable outcomes. So there was also a high level of neuropathy and myelosuppression associated with the use of linezolid. So there's actually a companion study called Xenix, which is looking at a lower dose and a shorter duration of linezolid in the same regimen to see if it still maintains the same outcomes. This is very promising, but this was a small study. The next TB study was a small study that was conducted in one country in South Africa with no randomized control group that received a standard of care. And it's probably not that the investigators didn't notice that, but leaving out a control group meant a much faster study. So there was a smaller sample size and of course no need for a 2-year standard of care treatment arm comparator. But as you can imagine, this also incurs considerable risk. And currently, of course, there's hesitancy to translate this into any guidance before there are actually controlled phase 3 study to evaluate the non-inferiority of this regimen. So although I left NIH about 7 months into our patient's treatment course, I was able to get an update from Kevin Fennelly, who, as many of you know, is a pulmonologist and senior research clinician at NHLBI, and has had many contributions to TB, including pioneering studies of measuring TB in aerosols. So this patient has done really well. We mentioned what the regimen that we ended up starting her on. There were a few tweaks in the beginning. She eventually discontinued linezolid due to paresthesias as well as cycloserine, and continued on a regimen of bedaquiline, clofazimine, levofloxacin, and protominid. And with a monitoring of her QT interval, which was approaching about 500. And I think with COVID, it sounds like there was less ability to accommodate visits, but she was able to buy a cardio mobile device, so has been sitting in her 6-week EKGs on a regular basis for monitoring. And it sounds like she'll be coming in for her final visit, hopefully soon, and consideration to stop her therapy, to complete her therapy now 2 years later. So adding to the theme, just my last few slides, adding to the theme of TB heterogeneity, we also see heterogeneity in response to different, heterogeneity in response to treatment among different types of TB lesions. So for example, we see that her cavity, the right apical cavity, actually improved over the first 6 months with TB therapy. And this is also courtesy of Dr. Chen, who is a staff clinician in the TB research section. He also pointed out that there are also areas, such as in the left upper lobe, that actually get better, but then get worse again 6 months into treatment. And I don't have her follow-up CT scans after this, but supposedly these lesions have started to improve again. It turns out, though, even though 6 months was still fairly early in her course, that even at the end of therapy, you can still have residual hot inflammatory lesions and even detectable TB mRNA indicative of ongoing inflammation and transcriptional activity, and yet still be cured. So this indicates, this study, which found this, suggested that really the role of treatment is to help clean up a big mess, and that the immune system is often there to mop up the rest of the mess. So I just want to conclude with a few words on pulmonary impairment after TB, which results in considerably increased morbidity and mortality. Prior to our patient from China, we had a patient from India, a 25-year-old patient from India, who was a bit different in that she had been treated on and off for TB for about 9 years and had quite extensive cavitary disease, as you can see pictured. She was treated with bedaquiline, clofazimine, linezolid, and meropenem plus clav. And she had a pulmonary impairment, certainly in the beginning of her treatment, but it actually progressed after therapy was started. So it turns out that this is quite prominent. Pulmonary impairment after TB is quite prominent among patients who are treated with TB. And some studies that have looked at this seem to indicate that roughly half of them actually improved during treatment. But then what about those who have a pulmonary impairment as a long-term sequelae? We actually don't understand very much about, there's a limited understanding about the pathogenesis, the clinical, microbiologic, and environmental and host immune factors that affect the long-term sequelae of PIAT. And this is one of the main objective of the TB sequel study, which is looking at 1,600 patients across 4 countries to answer this question. Meanwhile, interestingly, there are also host-directed therapy studies that aim to decrease the burden of, one of the aims to decrease the burden of inflammation of TB that have looked at PIAT as an outcome. So we've already begun to see the transition which will be going on in the next few years, not only in our understanding about the pathogenesis and spectrum of TB infection or the way we diagnose TB, but also in our treatment approaches. So we're seeing a transition from relying on phenotypic DST towards molecular DST in first-line drugs, and the work ahead is really to transition to molecular DST for second line and eventually newer oral drugs that will be used more and more for drug-resistant TB, as we understand the underlying molecular mechanisms that drive resistance for those drugs. We're also now seeing a transition towards shorter oral regimens for drug-susceptible and drug-resistant TB. And although I didn't discuss it in detail, we're also seeing increasing capacity to detect TB at an early stage. This is important because it's not practical to treat the quarter of the world with latent TB infection. So our increasing ability to predict which small proportion of patients with latent TB will progress will allow us to intervene before patients become sick and transmit. And how we're going to treat these patients with incipient, what we're calling incipient TB, is still to be determined. So put together, this transition we anticipate will have a great impact on our currently modest decline in TB globally. And so that's it. Just want to say thank you again, and I will take any questions.
Thank you, Linda. That was so great, particularly for somebody like me that doesn't think about this often at all. I guess if anybody has any questions they want to ask, they can just chime in because it doesn't look like there's anything in the chat, but while people are sort of thinking about it, I had a question in terms of, so, you know, in the US anyway, say we have the molecular results early in terms of the resistance pattern, and you start treating, and you actually do get eventually back the midget and the phenotypic sort of results that maybe would suggest resistance to a drug that you thought was sensitive, what do you do with that information at that point?
Yeah, I think it's a good question. So, at that point, it's probably now several weeks to months, right, into their treatment course. So there's some, of course, some measurement in terms of how they are responding to therapy. But if there's phenotypic resistance at this point, we're still considering that as a resistance, because there are more commonly cases where we see phenotypic resistance, but we don't have an underlying molecular mechanism of resistance. And this is especially, of course, with the second line drugs. So it's more commonly to see that type of discordancy. And so when there's phenotypic resistance, but no underlying mutation that we know of, we would still consider that resistant, especially for second line drugs, which we're still understanding the molecular mechanisms.
Sure. Okay, and then so Dr. Bennett did just put in a question into the chat. How common is permanent loss of vision with linezolid?
Yeah, so the optic neuropathy that's seen with linezolid, in some cases with stopping, so we've had, well, neither of our XDR TB patients, but there was a patient who had vision loss with who was on linezolid, and after stopping linezolid, was able to recover their vision. So in some cases, it can be recoverable, but there are also a proportion of cases where they still have persistent vision loss. So yeah, so it's a bit on a case by case basis, but it can occur both ways, especially with high doses.
Yeah, great. And then, so the follow-up question then just came up, anything to support advantages for tadazolid then?
So tadazolid was quite promising in terms of early bacterial cytals in vitro studies. But currently we don't really have, and supposedly, there's less toxicities potentially with tadazolid, but currently we don't really have much data or really any type of in vivo evidence to support the use of tadazolid. So it's really purely investigative when it's used.
Okay. And feel free to put anything else in the chat. I was just going to also ask how long for these complicated patients after stopping therapy, particularly with all those cavities, how long you typically follow them once you assume that they're cured?
Yeah, so it's a good question. So I generally, these treatment trials follow patients for about 6 months after they're treated to see if there's relapse. And so, yeah, so generally, once they stop therapy for the ideal scenario, follow them for several months afterwards to make sure that they don't relapse. And especially those who have really severe progressive pulmonary impairment, we sort of have to follow them anyways for a period of time after therapy.
Okay. Well, there's another question just came in. So the New England Journal article of different outcomes with similar MICs was very interesting. Has anyone looked at whether the resistance mechanism made a difference in outcome with the same MIC? For example, INHA versus CAT-G mutations.
Yeah, it's a really good question. So those isolates were whole genome sequenced. Because they didn't contain a lot of the canonical resistance mutations in RPOB or INHA and CAT-G. To be honest, I don't know exactly what the follow-up of that is in terms of what the molecular mechanisms they found in terms of sub-breakpoint MICs were. So I'd have to look back at that. It's a good question.
Yeah. And another question. So is VATS and partial pulmonary resection an option for some more refractory cases?
Yes, so right now the guidelines are more so in refractory cases, for example, if there's no if there's difficulty in achieving culture conversion, there's so the guidelines, one of the options in terms of treatment is doing partial resections, which currently that is still part of the treatments for drug-resistant TB, but of course it has to be individualized according to the locality of their disease anatomy. Of course, if they have more diffuse disease, then it's not very feasible to do resections.
Sure. Still part of the armamentarium. Is there any evidence for TB and COVID co-infection and any increased risk of worsening either disease? I imagine that's got to be an emerging topic right now.
Yeah, it's a good question. So TB and COVID, at least at least initially, we haven't found any specific driver of, for example, TB really increasing the risk of COVID and COVID increasing the risk of TB. There may be now some newer studies or epidemiologic studies that have looked at this, but at least initially we didn't really identify any clear association. Of course, one of the big considerations is that there's overlap, of course, in the way patients may present, and when we're considering TB diagnostic algorithms, we have to also consider COVID now within that algorithm. And actually, there's potentially some interesting work. There's interesting work going on in looking at co-diagnostic pathways for TB and COVID. Especially, there are some, in addition to sputum, there are some common specimens that might be used, such as face mask sampling or oral swabs for more high burden infection. And some, looking at assays that could potentially multiplex both diseases, both infections. So there's a lot of interest in that work there. And I think the other thing that we also recognize is that, COVID is, of course, imposed a huge burden in terms of the TB, the healthcare systems that have been in place for TB. And so there's actually some projection that by modeling that this could result in a huge number of increase of TB cases and more TB deaths. But I think we'll have to see over time whether that really pans out.
Well, really appreciate you coming, Linda. Thank you so much for taking the time. I thought it was a very, very interesting, very timely also with the recent results of the TB-TC trial. Thank you for everybody for listening, and we're going to post this then to our YouTube channel that we have now, and so that'll be up soon. Thanks so much.
Great, thank you. Good to see everyone.
I'll stop recording now.